Good day, everyone. Welcome, and thank you for joining us today on World Elder Abuse Awareness Day for what I know will be a meaningful and important conversation. My name is Kendall Ford. I use they and he pronouns, and I'm the Director of Project Management at Egal Canada. It's my absolute honor to moderate today's session on dementia and substitute decision making for 2SLGBTQIA+ communities. Before we begin, I want to pause to acknowledge that we are gathering on treaty lands. Egal Canada works across the country, land that is the ancestral, traditional, and unceded territory of many First Nations, Métis, and Inuit peoples. We hold that recognition not just as words, but as a commitment to justice that connects to the work we do today around dignity, rights, and community care. Let me introduce today's incredible speakers. Celeste Pang uses they, she pronouns, is an assistant professor in Women's and Gender Studies at Mount Royal University and the co-lead of the critical Queer plus Trans Research Hub. Dr. Pang's research focuses on aging, disability, and care access and equity with significant focus on 2S LGBTQIA+ issues. This session draws on research on long-term care and dementia and substitute decision making, funded by the Social Sciences and Humanities Research Council of Canada and by the Alzheimer's Society Research Program. We're so grateful for their presence and expertise today. Krista James uses she and her pronouns and is a lawyer, writer, feminist, and community organizer. She is currently policy director and senior legal counsel for Vancouver Coastal Health. She was a staff lawyer with the BC Law Institute for 15 years, including 11 years in the position of National Director of the Canadian Centre for Elder Law. She has practiced labor and human rights law and written and presented extensively on health law topics. Welcome, Krista. Together with Egal Canada, a national 2S LGBTQI human rights organization, these two experts bring a uniquely grounded, affirming, and justice-oriented lens to this subject. So for today's format, Krista and Celeste will present on their work. Dennis from our team is going to be in the background and will update the chat with links and resources. And we'll leave about 15 to 20 minutes near the end for Q&A. And then you'll be asked to complete a survey to help us evaluate today's session. And so we appreciate your cooperation with that. To set the stage, I want to invite Krista to walk us through the core legal concepts underlying today's conversation: capacity, consent, and substitute decision making. Krista, the floor is yours.
Thank you. Maybe Celeste, if you want to. Celeste is driving our PowerPoint presentation today. So, in collaboration with Celeste, I'd like to provide a bit of a legal foundation for some of the concepts that Celeste will be referencing in their presentation. So the legal concepts I'm going to be talking about are capacity, consent, and decision making. So I'd like to explain what is capacity or capability. You might hear that word sometimes. What is consent? And who makes your decisions if you can't make decisions for yourself? That's sort of the concept of substitute decision making. I'm a lawyer and I practice law in BC, but this presentation is not legal advice today. I'm here to provide a basic understanding of the law, and if anybody asks questions about their specific situation, I will just kind of deflect them, and I can possibly connect you with a nonprofit in the province where you live that can provide some legal support, but I can't answer specific questions about your situation. But I do invite you to kind of pop into the Q&A or the chat some questions about the law that are related to this topic if I don't cover them. I'm going to speak for about 20 minutes. Celeste, next slide. So what is capacity? Capacity is basically the right to make decisions. It depends whether you have capacity is about whether you have the ability to understand the information relevant to that decision that you need to make right now and apply it to your situation. So capacity is the term used in Ontario. In BC, we use the term capability or mental capability in legislation. You might hear the word competence, but it's about can you make your choices. Next slide, please. So in all kind of modern legislation that applies to, so legislation means laws, and all laws that apply to capability or capacity, there's this fundamental principle that all adults are presumed capable of making your own decision regardless of age or disability, unless like somebody's gone to court and got an order and a judge has decided based on evidence that you can't make your own decisions. So that if you have a cognitive disability or mental illness or dementia, we still start with that place of, can you make this decision for yourself? And if you can't, then we look at alternatives. So capacity is not assessed, and you might hear the word capacity assessment or capability assessment. I like to say that that's just like the wrong word. What you should be hearing is incapability assessment or incapacity assessment, because capacity is assumed and we're just checking to see if a person can't make a certain kind of decision. Next slide, please. So capacity is, generally speaking, decision or domain specific. Unless you're, say, in a car accident and you're in a coma, or your dementia is very, very progressed, then you might not be able to make any decisions. But most people can make some, if not all, of their decisions. So whenever you're in a situation where you're thinking about the capacity of somebody you care about or your own capacity, you want to consider, what is the specific information that a person needs to be able to understand to make this choice or figure out what to do next? And otherwise, every person with capacity can make their own decisions. Next slide, please. So what kind of decisions? There are so many different kinds of decisions that we make throughout our lives. And I like to say that like honoring autonomy is just where it's possible for folks to make their own decisions. It's ethically, legally, it's just very fundamental, because the autonomy to make our own choices is kind of what defines us as a person, right? You might have a disability and you might need help with some decisions, but maybe you can kind of still steer the ship of your own life. So there are lots of different kinds of decisions, and we really make decisions every single day. In a legal context, we might make some important decisions. And this slide shows you like examples of some important decisions that come up. So you might have to make a decision about a certain kind of health care. It could be a really complicated decision related to a surgery and understanding all the kind of side effects, or it might be a decision about, do you want to take a kind of medicine to help with your digestive issues, or some pain medication because you have a really bad headache if you're living in long-term care. You might be making some important legal decisions, like, do you want to changing your will, selling your house? Maybe you are thinking about getting married. We all make our own choices about our sexuality. You might be creating some kind of documents, making financial decisions, hiring a lawyer to represent you in different issues. And these are all different kind of choices, and you can be capable of making some, but not others, or all. Really, every person is unique. A really good example of how these tests for whether you're capable can be different depending on the context is, you can be capable of getting married, of saying, basically, I want to marry this person. It's a very low bar. In lawyers, we joke sometimes the capacity to get married is, can you say I do? That's pretty much it. But the capacity but you might be able to get married, but not able to change your will, because the capacity test for changing your will is much more complex. You really have to understand all your assets and the people in your life that you might have some kind of legal obligation to care for, like your children. So you have to remember people and know what you own and know what you could do with it. The ability to invest your money. You need to understand your money and understand investment. So some tests can be very low and some tests can be very high. It just kind of depends on the decision. Next slide, please. Capacity can also vary, like it's a point in time question, and lots of things that happen in our lives or in a given day can affect our ability to make decisions. So time of day, medication, whether you had a good night's sleep, the amount of stress you're under. Trauma can have a huge impact on your ability to make decisions and understand information. And for some people who are aging, like compounding health issues can stack up and undermine capacity. But then if we treat those issues like an infection, capacity can kind of come back. For people living with dementia, we often hear the expression sundowning. So people can have really good capacity in the morning, but then their capacity can deteriorate throughout the day. So what that means is you want to be supporting people to make choices when they're at their best. So decisions and appointments are often best for people living with dementia in the morning. But it depends on the person. You want to kind of understand them and understand yourself and know when you are at your best and time your decisions for when you can have as much capacity as possible, just because choice making can be so important. Next slide. So capacity is not communication. You can have trouble communicating, but still have all your capacity. My dad has some aphasia from a stroke, but cognitively, he's still very robust and can make his decisions, particularly if I support him, kind of identify things. It's not about risk. Everybody has a right to make bad choices if they understand what's going on. Somebody making risky decisions, like if you care about somebody, you're noticing changes in their decision making. That could be like a red flag if they are making risky decisions that don't align with who they've always been. But they do have a right to keep gambling away their money at the casino if they understand what's going on. But if they're suddenly going to the casino every day, that could be a red flag that you want to be curious about whether their capacity has declined. But we don't take capacity away because people just make choices that make us uncomfortable. It's about that person's choices. It's also really not about vulnerability. We don't legally take away people's right to make their decisions because they're more vulnerable to the outcome of bad choices. We support them to make good decisions where we can, and we kind of we can try to help them, but just the fact that you're vulnerable because you have a disease or dementia or trauma doesn't mean you lose your right to make your decisions. You may have a right to greater support. And I'm going to come back to best interest later because Celeste's going to talk about it and I want to tie it into decision making, but it's not really just about best interest, capacity. Capacity is always about what do you understand, and do you understand that this stuff applies to you? Do you know that here are your options for treating your cancer? And do you understand that you actually have cancer? Not somebody else, but you have cancer. Next slide, please. So I just want to show this slide, and I'm not going to delve too much into specific laws, but the laws related to capacity and decision making are created by province and territories. There's no such thing as a Canadian or federal law related to capacity. So if you're trying to think about what your rights might be or your friend's rights might be, you want to think about where does that person live, because that tells you which laws apply to them. And just to give you an example, I live in BC. There are so many different laws that apply to capacity. And so here's just, this slide has, I think, 8 different laws. They all have a kind of relationship to capacity. So if I'm thinking about the capacity of my daughter, who's a child, I'm thinking about the Infants Act and the Family Law Act. If I'm thinking about the capacity of my dad to make healthcare decisions, I'm thinking about, for BC, the Healthcare Consent and Care Facility Admission Act. If I'm thinking about my dad's ability to make a document for financial planning, I'm thinking about the Power of Attorney Act. So there's lots of different laws, and the laws that apply to you depend on where you live. Next slide, please. So here's the second concept I want to talk about. What is consent? And some ways to think about consent is really just agreeing or not agreeing. But consent is an informed, timely, voluntary agreement about a person who is capable, by a person who is capable, and in a healthcare context or personal care, of making that specific healthcare decision. So if I'm in the hospital and I've been in a car accident and a decision needs to be made about treating a wound, the nurse, the physicians, they're thinking about right now, can I make that decision? They have to give me enough relevant information so I can make that decision, because I'm not a doctor. They're going to tell me what could happen if I have this operation or don't have this operation. They're going to provide that information at the time. I can't be bulldozed or pressured or rushed. I get time to make an informed decision. And what I often say in the context of healthcare, because healthcare places can be really, really busy, is that In a healthcare context, consent right includes a right to the time of the healthcare provider to help me, to tell me what I need to know to make a good choice, to slow down, to explain the jargon, to support me to make that decision, and to use regular words where you can. And it might mean getting me a language interpreter because I don't speak that language, or it might mean letting my friend who understands me be in that room. I need to help my dad understand information if his aphasia is acting up. So they have to support you to make that informed decision in a healthcare context. Next slide, please. So there's so many different kinds of decision making, but I'm going to focus on health and personal care because that's I think where Celeste's research was focused on. So just fundamental healthcare consent law basics are no treatment without consent by somebody. Otherwise, it's an assault on my body. At law, remember we talked about the presumption of capability. When I come into that OR, everybody assumes I can make my own choices if I'm alert and not unconscious. If I don't make my choices because I'm unconscious or I have dementia and I need help, then somebody provides consent for me, and it has to be a person with legal authority to make that decision. Whether they have authority is going to depend on the laws in your province or territory. And that consent needs to be informed. Everybody who makes the decision gets the right information to help them make the right choice for this person. Next slide, please. Sorry about all the pinging. So in BC, and not every jurisdiction in Canada even has healthcare consent laws. I think consent laws that Celeste was mostly focused on her research is Ontario. There's a Healthcare Consent Act. I would live in BC, and so I'm often thinking about the Healthcare Consent and Carefully Admission Act. But only 5 of the 13 jurisdictions in Canada have consent legislation. So if there's no consent law, you're looking at judge-made law, which we call the common law. Basic fundamental principles. You can't touch my body without my permission. I choose, not the doctor, and I have a right to informed consent. That's kind of the basics at common law. Next slide, please. So who makes your healthcare decision? It's going to be you if you have capacity. You can appoint a substitute decision maker in advance. They're going to be called different things in different jurisdictions, and I have a slide to show you that briefly in a moment. In BC, if you're choosing a substitute decision maker for healthcare, we call it a representative. In Ontario, we call it a power of attorney for personal care. If you didn't have time to do planning or didn't think about it and you can't make your own decisions, somebody could go to court and get a guardian appointed to you for you. You can do some advanced planning, creating like an advanced directive of some kind to relate to very specific decisions. If you have capacity and want to get all your documents in place. Again, those documents are called different things depending on where you live. And if none of those things have happened and you're in the emergency department and somebody needs to make choices for you, legislation or the common law is going to determine how healthcare providers can get consent for you. In BC, the nurse or the physician would choose a temporary substitute decision maker, and that would be somebody in your family who's present, or a friend that is present, somebody who's kind of there, who can support you and who knows you. And there's legislation that identifies their duties. It's very hard to speak generally about all of Canada, as I said, because the laws are different in each province and territory. Next slide, please. So words are really, really important when we're talking about decision making for another person, whether they're your friend or your family. Anybody in Canada can choose somebody to make decisions for them. If they have capacity, the ability to understand what they're doing in appointing somebody for them. And it doesn't have to be a family member. It can be a friend, it can be your landlord, it can be your neighbor. Just it has to be somebody that you trust, and you have to fill out the right documents. So there's no test at the end of this presentation. I just kind of flashed this slide before you to help people understand that in every province and territory, the thing we call the substitute decision maker is different, and that can be really confusing. So in BC, we call the substitute decision maker you choose for yourself a representative. And you don't choose them orally, you have to fill out all the paperwork. Most jurisdictions, and when I say jurisdiction, I mean province or territory, have some kind of nonprofit or a senior center, or where law students or lawyers can help you fill out basic paperwork. And there are kind of do-it-yourself tools that are available online, but the documents have to be in writing. They have to be completed in a special way with signatures in the right place. So it's really important to get some support or guidance or read all the fine print when you're creating a document to appoint someone. I know Celeste is going to be talking about people who don't have family, but you can choose your friend, your adult child, like anybody you trust. Next slide, please. Some jurisdictions in Canada, you can also appoint somebody to be your decision-making helper. There's only like 5 jurisdictions in Canada where that's possible right now. But that's, I like to flag that because that's a good option for people early on in a journey with dementia, when you know your capacity can be varying across time. If you, in BC, you can appoint a representative as both your substitute and supportive decision maker. And then their authority kicks in right away, but they only provide as much help as you want and need, because you don't lose your ability to make your decisions just by filling out a document. Until you lose capacity completely, that representative is your helper. And filling out the document gives someone legal authority to access your private information so they can help you. And that's why these documents can be helpful. They help kind of bolster the authority of your family member or friend when you're at the bank or in the hospital. And people are like, your last names are different. Who the heck are you? You can show them this piece of paper that says, Daniel has appointed me as his friend to help him with decisions or to make decisions for him. Next slide, please. What is supportive decision making? It's kind of like what you need. So, do they help explain things? Do they book interpreters? Do they do research? Do they take notes so you don't forget things? It's just what you need. And I can later on, if folks want, send a video where these animated slides come from. Next slide, please. So just as an example to be a counterpoint to Ontario. So remember how I said if you didn't have time to appoint someone to make decisions for you, if you can't do it for yourself, in BC we have a law called the Healthcare Consent Carefully Admission Act, and it has a provision on temporary substitute decision makers. So this legislation allows healthcare providers to get a decision from someone if you can't make decisions for yourself and didn't have time to do advanced planning. We call the person a TSDM, or a temporary substitute decision maker in BC. So this is basically like a shopping list of people that the nurse or physician chooses from. It's got order of priority. So you see it starts with your spouse, not necessarily legally married, then it goes to adult child, parent, and it keeps going, and it includes close friend of the adult, people related by marriage. So it does include people you're not biological family with, and you have to be in contact with these people. So what the legislation also says for healthcare providers is they have to choose somebody you have been in contact with in the last year, who's you won't have a conflict with, like if there's an abusive dynamic. So like if you're estranged from all of your family, but your best friend comes to the hospital with you, the nurse has to choose your best friend to make decisions for you. Even if your dad you haven't seen in 20 years shows up. Estranged people don't have the legal right to be appointed as temporary substitute decision maker in BC. And so there was a lot of advocacy when this law was created to keep it a really open list. It's an imperfect list. It's kind of fairly colonial. It doesn't, it's very focused on biology, but it does have some flexibility. It gives both your children legal authority, so if they disagree, there can be challenges. So it's imperfect, but this list does recognize non-biological kin and chosen kin. I think, next slide. I think I just have one more slide here. So I just want to flag that substitute decision makers have legal duties. And this is true everywhere. Even if there aren't laws that have been created, the common law has a basic duty of a legal duty to do the right thing and to be honest. But if there's legislation, the fine print of the legislation might vary, but all legislation that deals with substitute decision making says basically there's a duty to consult and do what that person would want if you know what it is. It's not like you can do whatever you want because you have this authority and big responsibility of making decisions for someone else. Next slide, please. This is just a high-level summary of what the law says in BC. And you can look at legislation in your own time, but I just want to flag that these duties are significant. You have to consult the adults if they can talk about what they want, and maybe you can just tell by their nonverbal communication. You just have to check with what people want. You have to comply with any instructions they expressed while capable. If you don't know what the person wants now, or and you can't do a document you can look at, or notes on the fridge, or a journal entry, you have to consider their best interests. And the law in BC actually sets out what best interests are. It's really about knowing that person. But you don't go to best interests unless you can't communicate with them and can't see what they wrote down first. So there's a very heightened duty to, as a substitute decision maker, to understand what they would want and do what they would want. I think this might be my final slide, but let's just go ahead to the next one.
It is.
Yeah, so I think it's going to, so very, very high level. I'll take a look at the questions while Celeste presents. Thank you.
Great. Thank you, Krista. So Krista has just explained some concepts of capacity, consent, and decision making across jurisdictions and what is supposed to happen according to the law. So in this part of the presentation, before we get to the Q&A, I'm going to share some of my research. So this draws on research with 2SLGBTQIA+ people living with dementia, including within long-term care homes in Ontario, as well as research that has focused on people facing dementia alone, who may or may not be queer, trans, or two-spirit identified. And the goal of this is to kind of complicate a little bit of what Krista said in terms of what actually happens in people's experiences, how the law is or is not applied correctly, and what that means, particularly for thinking about our communities and folks who are facing dementia and trying to figure out kind of what to do, who their support systems will be. So I'd like us to think about together, what are those experiences of 2SLGBTQIA+ people living with dementia and their care partners when it comes to capacity, consent, and decision making, and also what issues may arise if someone is facing dementia alone. So I'm going to start, you'll see me looking down at my paper, by sharing a story about two research participants who I call Kay and Alice. These are not their real names, who I met while I was doing ethnographic research or participant observation research in long-term care homes in Toronto. Some of you present may also have your own experiences as community members, care partners, healthcare, social service providers that might also resonate or be quite different from this, that can also tell us something about how these ideas of capacity, consent, and decision making are understood in practice by a general public and also by care providers. So Alice was one of the first key interlocutors or research participants who I met while I was doing my fieldwork. I was introduced to her through the staff at one of the two long-term care homes in which I gained permission to conduct participant observation and engage, including through interviews with LGBTQ+ residents and frontline and managerial care staff, sorry. So Alice, as an out and trans woman, and also who's someone within this type of institution as one of very few out and visible trans people at the time, was kind of made hyper visible. Was that connection was made by one of the workers at the care home. Alice, who is now passed away, was a child of Polish immigrants to Southern Ontario and the holder of a master's degree. At the time that I met her in her late 60s, early 70s, she'd been living at that long-term care home for 3 years. I will note there was a somewhat complicated backstory to this. She'd originally been placed in a different long-term care home that hadn't gone very well due to various transphobic responses. And the solution had been to move her to another home altogether. So Kay was Alice's attorney for personal care. So Kay was present when I met Alice in her capacity as an attorney because Alice was understood to have a mild dementia, living with a Parkinson's disease that impacted her mobility and increasingly her cognitive capacity. So I will note here that kind of Alice's state of where she was at with dementia, mild dementia is not actually a diagnosis, was always very fuzzy, including as related by the care home staff who were charged with taking care of her. Kay was there because she had been appointed by Alice as her attorney. So Alice had kind of the knowledge, first of all, and the foresight to put together the appropriate documents when it was clear that her health was in decline. Kay had been Alice's landlady. So Alice used to live in basically kind of like a rented room in Kay's place as a tenant as her decline in health started to happen. And this is what prompted her to name Kay as her attorney. Prior to that time, Alice and Kay had known each other through queer community, but they weren't buddies, they weren't friends, they were more like acquaintances. So Kay knew a bit about Alice's background, some personal details, was very affirming of Alice in her gender identity and expression, and was a very, very strong trans ally, and decided to say yes to take on what Krista has described as quite, a significant role and responsibility of being a substitute decision maker. Alice did not have anyone else to do this, including family members, including friends. So the landlady became the closest person there, and lucky for Alice, Kay said yes. So Alice's health kind of declined while she was living with Kay, and together they made the decision to try to get Alice into a long-term care home. So this kind of is a hinge point, and we can talk about this in the Q&A, where a lot of the social norms and understandings of people changed. So in research I've done in long-term care, of course, they're whole complex people living there, whole complex people working there, but kind of these norms of how we treat people, how we think about age and ability, and also, as I've observed it, capacity and consent does significantly switch or can significantly switch when you enter this kind of institutional space. So from the moment that Alice entered long-term care, even though she was still capable of making decisions, Kay very much became the person who was turned to. And I mean this quite literally, like if you've ever been in a doctor's appointment and someone's always turning to like the child of the parent instead of the parent themselves, this was the kind of dynamic that started to happen. So Kay, did her job in really consulting with Alice about what she wanted, but the default among a lot of the care workers they were interacting with was to kind of bypass Alice altogether and go directly to Kay most of the time. And this included about all manner of decisions, right? From what Alice would wear to what was appropriate food and all these little minute personal care related decisions in the day to day. So in this situation, Alice was very much in luck. So Kay was a good, quote unquote, good actor. She wasn't there to try to steal from Alice, to try to deny her identity, and really did the best to care for her. She was also a very, very strong person, right? And able and willing to advocate in a healthcare context, and was able to manage her own time so that she could show up. There are other LGBTQ plus people who I worked with who had also appointed people who are not necessarily family members, but perhaps friends as their attorneys for personal care. but not everyone, right, has that same knowledge of how to work within a healthcare system. Not everyone kind of has that gumption to really, really advocate, and not everyone can take the time out of their workday or their various other obligations. Um, so that is a consideration to make. Kay was also, as I'd mentioned, very affirming of Alice and her gender identity expression and advocated really tirelessly for her. So, as Krista mentioned, across different jurisdictions, there are different names for substitute decision makers, different laws that apply. But essentially, Kay was charged with thinking about, especially as Alice's cognitive abilities declined, what were Alice's values and beliefs, right? And what did she know of them as someone who, again, wasn't a very best friend, but was a landlady and an acquaintance, right? What were her current wishes? So, how could she try to communicate with Alice verbally? What did she know about how to read Alice's kind of bodily cues to get a sense of how Alice was feeling and what she wanted? And to think about this idea around quality of life and what decisions would ultimately benefit Alice and what might not. So summed up differently, Kay was charged with trying to make these, really important and everyday personal care decisions in line with this idea of what Alice would have wanted, might want in the future, and could want all at the same time. She was the go-to person for everything. So to give you a sense, for buying new glasses, for buying looser socks, for taking Alice outside of the long-term care home for fresh air, she decided to run an activity at night because this was something that Alice enjoyed. She also was the person who shaved Alice's chest because this is what Alice wanted, and no one else would do it. She plastered Alice's long-term care home walls with reminders and instructions when I met them about how to put on and care for breast forms. And these were instructions that were also not usually followed. So she really played this kind of expansive advocacy role for Alice. And in the situation, I think took this appointment as a substitute decision maker very, very seriously. So as Krista mentioned, like having your documentation in place can give you some kind of authority, legal authority, but also this kind of social recognition. And in this situation, because she was just kind of could be read as the random landlady, this documentation actually did make a huge, huge difference for how she was taken seriously in what she was articulating on Alice's behalf. So again, Alice was quite lucky and fortunate to have Kay around. Not everybody does, especially people who may not have strong family or friend networks for whatever reasons. We'll share some resources at the end, but among 2SLGBTQI people living with dementia, there are various specific challenges and concerns that people may have. So this includes concerns about not having gender identity and expression recognized and facilitated. So I gave the example, of Alice needing help eventually getting dressed, right? So that would be an example of facilitation of do care staff have the knowledge, the will, and very importantly, the time to help someone express their gender in the way that they want to, if they're not able to do that fully themselves. People can have concerns about having relationships recognized, including intimate partnerships, concerns about forgetting important aspects of identity, and memory and sense of self does change with dementia, right? So this is a reality for anyone, regardless of sexual orientation or gender identity. And concerns about discrimination, especially in long-term care homes. These are all kind of documented and known community conversations. So we will provide a link to a brief that Krista and I wrote a couple of years ago at the end. But if you are thinking about, who could be a substitute decision maker for you, where you might live, there are a number of considerations. So do you have someone who knows you well, who will listen to you and respect your wishes? And this could include changing wishes. And as Krista mentioned, this could include your wishes to make what may be perceived as bad decisions, right? So not someone who will necessarily just make sure you're always on the kind of good, right track, but who sees you and will try to help others to see you and respect who you are. Someone who's comfortable communicating with healthcare professionals. This came out really, really strongly across my research, having that kind of person around can make a huge difference, and who will advocate for what you want. So before we move to the Q&A, I just want to speak a little bit to this question of, what happens if you don't have somebody who you feel you could name as a substitute decision maker, and what happens for people who are facing dementia alone. So Ontario is the main province in which I conducted my research on this subject. Differently from BC, kind of in that hierarchical order, we don't see friends appear, which I think is quite significant. And I'd also love to learn more about that advocacy that went on around that. So if you haven't named anyone and there's absolutely no relative who can act as an attorney, the kind of very last option is an entity called the public guardian and trustee. So this is essentially a government entity which will appoint a representative. Sometimes this can be a social worker type person to someone who has no one else. So kind of by definition, this is a stranger who's going to become charged with making decisions on your behalf if and when that's needed. In my interviews with social service workers working in the elder care sector and in long-term care, I wasn't able to speak to a public guardian, but I did learn that many of them have extremely high caseloads, don't really have time to get to know their clients, and barring urgent circumstances, especially in long-term care contexts, may only meet with clients and other paid care workers once or twice a year. So it kind of gives you the sense of strangeness, right? About how are you trying to make a decision for someone who you really don't know at all. I also learned that care workers will go to really great lengths to try and find anyone at all to be a substitute decision maker. So this could include simply asking, do you have family members on this list, to scouring through medical records and charts to see if they can find a phone number for anyone and trying to discern or, make some kind of tangential link to how this person is a relative before referring to the public guardian and trustee. And part of the key here, I think, for us to think about is familiarity. So Alice did have some distant family members who were estranged from her, who in Ontario could have kind of petitioned to be a substitute decision maker, but didn't want to be involved in Alice's life and wouldn't necessarily have been that person who would see her and respect her. And this is how kind of Kay became that person. So again, the significance of having someone, finding someone, even, maybe strategically developing a relationship with someone so that there is someone who recognizes you who might be there. Often kind of in the research literature, and I think also in public conversation, this idea of kind of the lonely older adults or the socially isolated older adults can often kind of conjure up this image of someone who doesn't have family members. As we know, in 2SLGBTQIA plus communities, you can have family members, but you may be estranged from them. They may not respect your life choices and identity. So in my research, I've really come to think about, what does it mean to be alone? Doesn't mean not having anyone, but it means having no trusted others, no familiar trusted others around you. You could have friends, you could have family, but that doesn't mean that those are the individuals who fully see you and would be able to advocate on your behalf. Not having prepared kind of a range of advanced care planning documents, as I've witnessed it, can kind of make people more alone in the sense that they haven't formalized some of these care links as well. So in conclusion, before we get to the Q&A, how can we support 2SLGBTQI plus people living with dementia, including people who are facing dementia alone? I think having conversations about substitute decision making, about advanced care planning in your jurisdiction with your friends, family members, significant others is very important. Creating space for these conversations. Dementia is not a sexy topic. Aging and losing various capacities are not necessarily something most of us want to think about in our society. But creating space for that, including within community groups, I think can also reduce some of that stigma or fear. Seriously consider what it means to be a substitute decision maker or care partner and what you need to know, and trying to get that knowledge ahead of time. Advocating for affirming care in all contexts, so including if you're a healthcare provider in a long-term care home context. recognizing different kinds of significant relationships. So this can be socially, right? Thinking about the importance of friendships, and also in legal context, thinking about where these non kind of biologically related relatives of ours are recognized or not. And then also remembering, if you're a care partner, that the person you're caring for, who may be facing dementia, is a complex human being. And dementia brings changes. So I've seen examples where people have identified a certain way all of their life, had certain preferences, and not by virtue of any particular power dynamic, but that's just changing, right? So also being able to kind of grow with that change and potentially grieve people, as they change when they're still alive, and still doing your best to, if you're in a substitute decision making role, to make decisions that you think they would have wanted also as they continue to change as a person. So I'll leave it at that. We have some resources here, and this is being recorded, so these will be made available. But I'm going to hand it over to Dennis and/or Kendall now to facilitate the last part.
Terrific. Thank you so much. It was great to hear from both of you, Krista from the legal side and from you, Celeste, from the research and community side. And so I want to open things up a little bit for a dialogue between you and some questions from the audience. We did see a question coming from Shelley earlier on in the chat. If I live in one province and the healthcare provider I'm dealing with is in another province, which provincial laws drive the consent and decision making? And Krista, I saw your response there saying that the laws that apply are the laws where the person receiving care lives. So thank you for that.
And I can elaborate that. Maybe I'll elaborate that on that a little bit. So
Please.
usually, generally speaking, the person who is receiving care and say the nurse or the doctor are in the same place, and you might have family members or helpers who live elsewhere. So it's the law that applies is where that person is receiving care. So in a hospital, long-term care home, in their house. Healthcare workers also have a professional obligation to follow the professional regulation rules that apply to where they live too. So that's other rules that they have to follow. They will align with the law. It would be, I'm assuming with the question from Shelley that the person is not somehow receiving care through across a border from a nurse, but please elaborate if the person receiving care and the healthcare professional are not in the same place.
Thank you. Yeah, and so Shelley, you can participate in the chat if you've got some further context to provide. And so I'll invite everyone to use the Q&A or the chat to drop in your questions. I see one here from Ahmad, and that kind of links to Ken's point earlier too. Ken was saying that we're often forced back into closets, especially when a lot of care homes are not so inclusive. And so Ahmad is asking, how can healthcare providers advocate for the dignity and wishes of 2SLGBTQIA plus individuals when legal decision makers do not align with the person?
That's a great question, Kendall. And that happens. It does happen all the time. Well, no, it does happen. So I can speak to that, particularly in BC. Remember how I talked about duties? And so one of the duties that a decision maker has is to respect the values and wishes of the person. Now, if a nurse sees that a substitute decision maker is not respecting rights, they do have some capacity to action that, depending on what kind of decision maker they are. So if it's a family member and there's no legal document, so it's that temporary substitute decision maker chosen by, or next of kin chosen by the nurse, which is the most common context. Because let's face it, most people don't do advanced planning. The nurse can disregard anybody in that list who's not respecting their legal responsibilities to respect values and wishes. So say, for example, somebody has 2 adult children, and the 2 adult children disagree about what kind of care their mom should be receiving. The nurse is going to have to, and social workers and doctors have to figure out how to navigate that conflict. But if one of those decision makers is disrespecting the values and wishes, they can disregard that person and go to the legal go to the family member who's fulfilling their legal duties. It's more complicated if it's somebody who's been appointed in a document. Then you really have to either go to court to get that authority removed, or you can, in some jurisdictions, the public guardian trustee will step in if a decision maker is not doing what they should be doing. But the other thing I think informally that healthcare workers can do, and they do all the time, is they remind people. Remember, your job here is to help so-and-so make, what would they want? And we have this thing where they told us, or we just know them because they've been in and out of the ED for 20 years. So the nurses can really be advocating gently for respecting wishes. And often we refer families to social workers in institutional settings when there's a disconnect between values and wishes and what's being done. Social workers can do an amazing job mediating and helping to kind of elevate what somebody would want. But these are really our real life problems that happen all the time, and there's just no substitute for having hard conversations with as much patience as you can. And healthcare workers can be heroes, in supporting this.
Krista, I don't see any other questions coming in, but I guess to your point of people not really being good at pre-planning, for someone watching today who's been putting off that conversation, what would you say to them right now to get started on selecting a substitute decision maker?
Well, I think we have that slide that Celeste shared that we developed Celeste and I developed together a long time ago, is, think about who knows you, who do you trust, who do you think can have those hard conversations when needed. Who are you willing to have hard conversations now with about what you would like to happen if? Because substitute decision making is a really hard job, and it's especially hard if you're operating within a vacuum of guesswork and remembering. It really is helpful if you can tell your best friend that you really you don't want aggressive measures if this is happening, because it is a hard job. It's very hard to make hard choices that precipitate death or elongate suffering when you just don't know what people would want. So it is a big job.
Another thing, see something coming in here from Shelley. If I live in a different jurisdiction than my healthcare provider, like a therapist, which province governs the SDM? This is in the Q&A.
Okay, well, there's two things that apply. That would be a strange thing. So your nurse is in Ontario and you're in BC. Let's give you an example. And somehow you're receiving long-term care through a telephone or Zoom or something. The laws about substitute decision-making and advanced care planning documents are your laws, Shelley. So if you're in BC, you can choose a representative, and there are sort of jurisdictional reviews about recognizing documents created out of jurisdiction. However, at the same time, that nurse has to follow all the legislation that applies to her job as a nurse because she's a regulated professional. So there are best practice standards and that she has to follow as well. So that can be a little tricky if you're receiving care across the border. But what you would want to do is get a docket. You appoint a substitute decision maker that's going to ideally live close to where you live and understand the laws. But that's I will say it's a troubling scenario to me. If you're receiving health care from someone who lives far away from you, I just would want to I wonder how you get the best care possible across borders. That seems unusual to me. But the laws that apply in terms of substitute decision making are the laws where you live as a person receiving care.
I'm just wondering about that intersection between both of your presentations. Just what's the sharpest tension between what the law provides and what 2SLGBTQIA plus people actually need? Is the law catching up? Is it falling behind? Is it moving in the wrong direction?
Well, I think a really interesting piece to me about the story about Allison Kay that I think is worth highlighting is that she was receiving different kinds of support. And in that case, the decision maker is doing stuff beyond decision making. like chest shaving, putting things up the wall, that's more than decision making. That's providing ongoing support in other ways. And sometimes you need a village. Like, I encourage you not to think about one person because as it's a lot of work also supporting. So, who are all the people that will support you, and what are the different jobs they might be able to take on, and also to support each other in this complex journey and supporting you to have the best end of life and death and experience of frailty. But in that case, I guess the substitute decision maker is doing everything, but it doesn't have to be that. And when you have allies there for the decision maker, that's also going to be helpful because it won't just be her against the machine. Like, you have two best friends and and the sister in. You can advocate better collectively, and reinforce messaging and have more vigilance about quality of life. So I would encourage you to think beyond the box of one person.
Yeah. I'll also add that people, in terms of like the application, again, what is supposed to happen and what actually happens, like people can have a lot of confusion and concern about the application of the law and also treatment of 2S LGBTQI plus people, especially in long-term care. I'm seeing a question in the chat related to that. One thing that I'd underscore is, of course, that's terrible, right? Experiencing any form of discrimination, especially in an institutional care context where often people can't physically leave themselves, don't have the means to leave, don't have other options for that level of care. It's really sad and unfortunate that that happens. In long-term care home contexts, I think that one of the key ways that we can support our community members is to also kind of fix the system, which isn't, it's a big thing to do, but in my research, like with Allison Kay, for example, Alice, as I mentioned, wasn't always dressed in the morning according to, how she wanted to present her gender, right? Or had expressed she wanted to do that. A lot of that was read as simply transphobic. By benefit of kind of being there into the day to day and seeing what was happening, I came to understand that most of the staff, of course, there are people who hold transphobic views. Most of the staff wanted to support everybody, right? But most of those staff are underpaid, overworked, racialized people, newcomer people, and they had about 90 minutes each morning to get about 12 people dressed into the breakfast, right? That's very short amount of time per person. That is not to say that they shouldn't have, facilitated Alice's gender expression. They absolutely should have, right? But in order to do that, there needs to be more time. There needs to be more staff. They need to be able to get that familiarity with the people who they're seeing every day to also be able to advocate for them. So I think, again, of course, there can be problematic individuals or even long-term care home cultures that need to be addressed. But one of the key factors that I've seen in my research is simply time, to really get to know people and support them in a holistic way. And if you have a system in which you have 10 minutes to get someone fully dressed out of bed and down the hallway before you run back to the next resident, the chances that is going to happen for anyone, is pretty slim, and understandably so.
Yeah, that's wild. It takes me an hour just to do my eyebrows.
Exactly. Exactly.
I see
Yeah, I
chat
would say
people.
everybody who has a good experience of living in long term care has people who come in on the daily or weekly just to bolster what's possible from staff because it's true, staff do not have enough time to provide everything that permits the best quality of life in long term care.
It's just a good time. Okay, so we're at time. We do have some other things in the chat. So thank you, everyone. We're going to close the questions now. So before I close, I want to make sure everyone knows about the resources that Igal and our speakers have pulled together on the topic. And so thank you so much to Dennis for putting those things in the chat. Feel free to scroll through, access, and bookmark and share. I want to close the conversation by thanking both Dr. Celeste Pang and Krista James for your generosity, for your expertise and your commitment to this community. Um, on this day, the conversation is not just timely, it is essential. And to everyone watching, the most important thing you can take away today is not just information, but a conversation. Have it with a friend, have it with your family, have it with your community, the people in our lives. deserve to be known, to be named, and to be cared for in their own terms, no matter what the future holds. So thank you all for being here. This recording will be available through the EGAL channels. And so thank you everyone for joining and have a gentle evening. Bye.
Thanks, everyone.